PMS stands for premenstrual syndrome versus PMDD is premenstrual dysphoric disorder. So both of them do have some overlapping factors that come up in both of them. Like mood changes can be a factor both in PMS and in PMDD. But often we do see in PMS, you have as part of that diagnostic criteria, it's either the mood changes and or some physical changes, as in like the breast tenderness, cramping, like some of those things that we mentioned before. Versus in PMDD, we tend to see it as more mood related as far as symptoms go for patients. Often we do see that it's quite severe ideology when we're talking about PMDD. And a lot of my patients too have those PMDD symptoms even in those 2 weeks before their period. So by the time ovulation happens, they're already starting to see those mood changes and those mood shifts.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast.
Hello, everyone, and welcome back. I am so excited to dive into all things period report card, as I call it today, with Dr. Michaela and Dr. Heather, both of whom are at our Brooklyn clinic. And we're just going to be navigating what is normal, what is not with periods, what do people think about, what do they not think about, because that is just such a huge piece of the conversation is what are you not factoring in? What are you not thinking about? What do you think is normal? That is absolutely a sign of dysfunction when you're in our offices. So, we are going to dive in with that. But first, to get started, you guys haven't had your intro podcast. And so, why don't you give just a quick 2 or 3 minute rundown about who you are, what you love to treat? We're all in a similar period of life at the time of this recording. Heather's pregnant. Michaela's got a new baby. I have a spicy Latino. Michaela's partner and my partner are apparently cousins at one point. So we've got the Latino vibe going on. So give them a little rundown about who you are and what you're about and what you love to treat.
Okay, I will go first. I am Dr. Heather. I work at the Brooklyn location and I love seeing all things like reproductive health, obviously pregnancy, postpartum. I think I'm one of the only people on the team. I think we've got a few in BC now that actually like to treat kiddos. So I love seeing the kiddos and the littles as well. So that's a lot of what I do.
So, and I am Dr. Michaela. So, again, working at the Brooklyn location. I've been with Advanced Women's Health for over 4 years now, which is crazy. So, I started out in Kingston and mostly online. I also treat mostly women's health, as most of us do. So, anywhere from periods to menopause is kind of what I like to tell people. And so, as soon as you start menstruating until you stop, and after that, because people still need a lot of support. And I do see a lot of that in my practice. So, lots of, I would say, my main population is like 25 to about 55 typically is kind of what I see. So lots of period related issues, fertility related issues. Perimenopause is a big one we're seeing a lot nowadays. So all that good stuff where we need support with all these changes we go through.
And Michaela was the first talk in. She was the person during COVID that I was like, I need please help me because I had such a big wait list. So back in the days when we didn't envision having multiple locations and all these team and like all this stuff. So Michaela's seen the gamut, but she also is unfortunately, I don't want to say a victim, but you have to know everything. Like you came in and you were just like, okay, Sarah treats everything from periods to weight loss resistance to chronic fatigue to crazy digestive issues. And you just took it like a champ. So yeah, you're one of our oldest docs around. You got that award.
Woo!
So let's dive in and talk a little bit about what a normal period should be. So, Michaela, I'll get you to run like what is a normal period? And then Heather, give me some context of what are some red flags that people often think of as normal that are very abnormal.
Okay, so typically a normal period, there are different characteristics we'll think about when we think about the period. And so those can be the length of your cycle. So we measure that from the first day of bleeding to the first day of bleeding on the next cycle, which again, even just starting, that's a common thing. A lot of people don't necessarily know. So right off the bat, it's like, piece of information. So we're looking at cycle day length. So from first day to first day, how long someone's bleeding, how much you're bleeding, and then we'll kind of take a look at symptoms throughout the cycle. Those are kind of the four things that we would use. So with a normal cycle, we should be seeing cycle days between usually 28 to 32 is kind of where we like to see things, right? As soon as we kind of go outside of those days, we will kind of start thinking if something might be going on. We should be bleeding around 4 to 6 days on average. Again, there is individual variability. And then with volume of flow, it's always a difficult conversation because there are like milliliter amounts, which a lot of women aren't necessarily measuring, right? So I can say like, oh, around 30 to 80 milliliters of blood. And like, how do you measure that, right? Maybe with a cup nowadays, but it is difficult. But you should be using, it's so much easier to describe it as what's not normal, but we shouldn't be having to use pads and tampons at the same time and not being able to sit through a meeting or sit through your morning commute type of thing. So a couple pads or tampons per day would be considered normal. And then what should be normal is not really a lot of symptoms throughout the cycle. So we shouldn't be, oh, let's Heather go towards what would be considered a,
I asked a very hard question, clearly.
how do you explain normal without highlighting what's abnormal? But in a perfect world, we'll say you really shouldn't have a lot of symptoms throughout the cycle. Yes, there are hormonal fluctuations and hormones are going to make us feel different types of way, but it shouldn't necessarily impact your ability to show up and what you need to do. So we'll leave normal as like you can do all the things that you need to do in your life. You're not that impacted by those symptoms.
And this is something I talk about a lot, and I'm going to get a lot of hate for it. I'm very available for that because welcome to controversy in medicine. The concept of cycle syncing, I think, in many situations is feeding into normalizing an abnormal cycle. You should be able to do your P&L and focus at any damn day of your cycle. You should be able to lift weights any damn day of your cycle or do HIIT any day of your cycle. And now I know a lot of these concepts are not saying you can't do that at different parts of your cycle. They're just saying if you want to maximize this type of exercise, do it here. If you want to maximize this type of thing, do it here. But I think it's being misconstrued in a lot of situations. And I can say that working with patients, they're saying, oh, yeah, I know I'm doing cycle syncing because I can't do HIIT training 5 days before my period. I'm exhausted. My body hurts, my back hurts. And so I'm just focusing on something different. I think it's really well intentioned in terms of getting in touch with your body, getting in touch with different periods of time, different focus and motivation associated with testosterone or estrogen or whatever. But I think it's being taken in the mass market as an opportunity to normalize lack of function and lack of ability to do things at different parts of the cycle. And I think it's a really slippery slope. And we need to know where we are on that slope. So I didn't talk too much. And then we're like 7 minutes in and I'm going. So
I feel like that's important to say though, because I think a lot of times as women, we're made to feel like our bodies are confusing. And I think that happens a lot more, especially like when we're talking about periods. And it's one more thing like, oh, because I'm at this point in my cycle, therefore I can't do this type of workout or this type of thing. And I think that just reiterates this idea that as women, we're confusing and our health is confusing and we need like advanced treatments. And I think there's a lot of times that can be really detrimental to us.
Yeah.
amen.
Like not listening to your body. You know what I mean? It's like here, you should be doing this thing at this part in your cycle and this thing here. It's like you're not just intuitively listening to what your body needs in that moment and how it feels. And you're just allowing outsider things to determine what you need to be doing and what's best for you, which you need to be intuitive.
But we need to get into those fundamentals. Like, in order to be intuitive, you need to have your inflammation low so that your brain is not hijacked by inflammation. You need to have your bacteria under control. Your insulin and blood sugar need to be regulated. These are all causes of stress that separate you from your intuition. And if people feel like they go to these cycle syncing programs and they go to, I'm using that as an example, but you can use anything as a step away from your intuition because they don't have an intuition. And I hear that all the time. If I followed my intuition, I would eat Cheetos and lie on the couch and watch Netflix. And I'm like, first and foremost, that's not your intuition. Promise. And second, that's just a sign of fundamental physiological issues. Welcome to our 48-hour podcast, everyone. We're going in. But let's get into some of the deep, like the sources of dysfunction. Some of the things that people are like, oh, yeah, this is normal. That's not normal.
Yeah. I think this is something that I talk about with my patients a ton is this idea of like, just because it's common doesn't mean it's normal. And I think this happens especially with periods that I've had so many patients that are like, oh yeah, this and this and this happened with my period. And they're like, but that's normal. Everybody has that. And I'm like, it's common, but it doesn't mean it's normal. I think definitely like one of the big ones that we talk about a lot is pain and cramping. Honestly, like we really shouldn't be seeing any of that for the most part. And when we're seeing that, especially to the point of, as Dr. Michaela said, that it's debilitating, that you're really having a difficult time functioning, that's definitely something that we look a lot deeper at and try to figure out, okay, where is that coming from? Where is the source of that? And that you also don't have to struggle with that. Other symptoms and stuff that we do see a lot too are like period poops. So I think a lot of people talk about that their bowel movements change. And yeah, even since I've been working at Advanced Women's Health too, I think that's been something that I've seen a lot more with my patients and been investigating more with my patients. And we'll talk about some of the underlying causes for some of these things. Other things as well, like breast tenderness, mood changes for sure. Obviously, there's different variabilities of those mood changes, but especially if that's becoming debilitating, as we do see with some of our patients. Sometimes, like 2 weeks out of every single month, they're having debilitating mood changes, and that's definitely not normal. If you're having super, super heavy flows, as Michaela was saying as well, lots of clots in your flow, headaches before your periods, really scanty flow, spotting before your periods, spotting after or in between. A lot of these things people just think are normal, but it tells us a lot about what is happening in your body and what's happening with the rest of your health when we see some of these things showing up.
One thing too that's uncommon that is becoming more common that I always love to point out because these are the messages I get at 11 p.m. from my friends when I'm asleep is flu-like symptoms. Like I remember one of my friends slash patients, we don't cross over. She was like, I get sick every month. Like, no, you don't. Rashes, things like that that come up because your hormones and your immune system dance. Like they are in function together and they're in dysfunction together. And I think those are some of the ones that I'm seeing a lot more recently that people are just completely normalizing. And I'm like, you think you have strep throat once a month? Like, I don't think that's the case. These are immune system challenges due to hormonal fluctuation. So let's dive a little bit deeper. So, what are some of the conditions that we're looking at and the causes of some of these symptoms? Why don't you grab one, Michaela, and run with it? There's like 50. So,
Well, I'm naturally going to grab endometriosis because this is definitely where I like to spend a lot of my time. And so we'll get into it deeper, I'm sure, in the future. But endometriosis, the things that you're normally going to see with your period is pain is going to be kind of the biggest one, right? So that can be pain throughout during your period when you're bleeding. That can be pain cycle long, pain during ovulation. Other things that can come up, you can get really heavy bleeding with endometriosis as well. So some people experience no pain and just have heavy bleeding. And then, as you were saying, Sarah, with the flu-like symptoms, you see that a lot with endometriosis as well because it is so immune system based and inflammatory as well. So that's a big one. I see more of that than I wish I did, but I see that a lot in my practice.
so when you say immune system based, I need you to break that down for us because I have endo, as we all know, and as I've talked to it on the podcast, and will continue to. I think like March is going to be full on endo month on this podcast. So we will be going really deep into it. But so many people think Lupron, the birth control pill, an IUD is going to fix their endo. So can you walk us through why that's not the case?
So with endometriosis, you're really looking at dysfunctional immune mechanisms and inflammatory mechanisms as well. There is a hormonal piece to it, but it's not the only picture. And so that's why when we do things like Lupron or we take a birth control pill or we use an IUD, we're not necessarily changing the core dysfunction, which is lies in the immune system and inflammatory mechanisms. And we can get deeper into it, but we're going to look at why.
Yeah. I'm about to ask what's the immune
Yeah,
system
okay.
and inflammatory mechanism. So I am the audience in these videos, which absolutely messes with our doctors' brains because normally I'm challenging them on the other side to be like, think about this specific cytokine, blah, 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 blah. And then I come on the podcast and I'm like, what's the immune system? And they're like, excuse me, ma'am. So break that down. What do you mean by that?
I like to kind of break it down to patients as like in endometriosis, we're getting uterine tissue growing outside the uterus. That shouldn't happen. Your immune system should be like, hey, that shouldn't grow there and get rid of it. And so that's how I really simplify it for patients is your immune system is dysfunctional. It's not catching the fact that tissue is growing where it should not. And in growing that tissue, it's growing its own nerve supply, it's growing its own blood supply, all things that shouldn't necessarily happen. The tissue is very inflammatory, so it's releasing inflammatory cytokines, which can cause lots of pain. We can get into like there's a large connection in this population with gut microbiome. So, is inflammation coming from the gut microbiome? Is that chronic source of inflammation causing the immune system to not essentially know how to create a proper response to things? Is it using over inflammatory responses? So that's a big one. We talk about histamine a lot as well in endometriosis patients. That's part of our immune system. It can change pain pathways, it changes blood flow to areas. And so, all those things that are impacted as well with endometriosis. And then the other part that I always like to talk about is the nervous system changes as well, especially when it comes to pain. We do see alterations in how the body sends pain signals and how it perceives pain signals. We now come full circle because we think about how, okay, well, inflammation is going to change the nervous system. That's going to send more pain signals and stronger pain signals. We talked about period pain, right? But we don't necessarily see pain just localized to the pelvis in endometriosis. We see it linked with things like migraines. And like you said, those sleep-like symptoms.
Yeah, definitely. Awesome. Very good. What's another one we want to jump into, Heather?
Yeah, definitely another one is PCOS. There's a lot of people that talk about that. And if you haven't listened to Dr. Michelle and Dr. Sarah's podcast, you should do that. Stands for polycystic ovarian syndrome. And so it's kind of a spectrum, but we do have the three main Rotterdam criteria that are part of the PCOS diagnosis. One of them being that you actually have the presence of cysts on your ovaries, the other one being that you have anovulation, or usually that shows up as missed or irregular periods. So that's one of the big symptoms that patients come in with, being like, I haven't had my period in quite a few months, or sometimes years, or it's just all over the place. And then also having high androgen levels, being like testosterone, DHEAS. And that usually shows up for people with things like acne, excess hair growth in places that they don't want it. Those end up being a lot of the symptoms that we see as far as period changes. But with that, especially if we're not having that ovulation process, then we're also often seeing differences in just the amount of pain that you're experiencing with your period as well. Some more of those other changes that you're getting as you're having lower progesterone levels if you don't have all that ovulation happening. So those can also show up with some of those other symptoms too, like the breast tenderness, the enlargement, and a lot of those even mood changes that you get around your period as well.
Very good. Okay, Michaela, you're next. Hot seat. I'm actually going to rapid fire questions to you guys at the end. So if you see my eyes light up, it's because I am preparing.
I
So
love it. I was like, we're going to talk about the brain stimulating the ovaries and how the whole cycle starts. Here we are. So, Heather was talking about PCOS, and something that I also see a lot of that sometimes gets misdiagnosed as PCOS, or people come in, they're like, I think I have PCOS. I was Googling and I have all these symptoms, would be insulin resistance. And so, we're kind of getting into the realm of different hormonal imbalances, but insulin's definitely a big one, and it can definitely look a lot like PCOS. And I think the last time I wrote a blog about it, it was like 85% of people with PCOS have insulin resistance. So there is a really big overlap between these two conditions. But essentially, with insulin resistance, if your body, this is getting into lots of physiology, but simply put, your body is over producing insulin in response to what it normally should. And insulin, every hormone, as Sarah says, every hormone affects every hormone. And so insulin can start to create changes in the cycle. It's a growth hormone. And so we can get thicker uterine lining, so we can bleed a lot heavier. insulin at the level of the ovary and at the level of the skin will produce more of those androgens, so those testosterones and DHES that Dr. Heather talked about. And so it can impact things like ovulation, and we can get symptoms like hair growth and acne, which is why it can look so much like PCOS, but what you're treating can sometimes be quite different. And so that's another big one that we see too.
Proper diagnosis, honestly, is what it comes
Yeah.
down to. Like, it's
Investigate and know what you're dealing with.
it sounds so silly. In today's day and age, we have access to more data at our fingertips than we ever have before. And I think that has resulted in more misdiagnosis than I have ever seen before in my practice. You combine that with challenges within the medical system, all of those things. But truthfully, I say to patients on an almost daily basis, respectfully, I don't care what you've been diagnosed with. I care about your symptoms. I care about your experience of your body. I care about what you're going through, and the diagnosis will come. But we tether so hard to a diagnosis because we think that's the answer. If someone tells you your symptoms are legitimate, then it must be true. And if someone tells you what it is, then that's the only way to get treatment. And that is so wrong and so backwards. And I could do 20 TED Talks on this specific subject. You can get better with or without a diagnosis because there's only 5 to 7 causes of disease. Full stop, point blank, done. Every diagnosis fits into a category of a greater health function. And I think the more we can embrace that and understand that, the less people we're going to have calling the office being like, well, I don't have a diagnosis, so I don't know if you can get me better. And I'm like, even if you had a diagnosis, I probably wouldn't believe it until I prove it true myself. So it's just this whole shift in mentality and mindset that women need to have about around their menstrual cycle. It's a huge change that we need to take on from a societal standpoint. And there's all this pushback right now against the functional world looking for problems and biohackers and how that's impacting things. And to me, it's just a fundamental change in the fact that women are now standing up and saying, I can feel better than this. And you may be gatekeeping that information, but you're not gatekeeping my body. And so I will use random ass tools sometimes, or very legitimate, like I'm wearing a smart ring, right? Many of us have these devices, but then there's people online that are misinterpreting that data because it's newer and or they haven't done the research. So if you're feeling overwhelmed, if you're feeling confused, if you're trying to grasp to a diagnosis because you think that's going to give you clarity, I hear you. I get you. I don't blame you. And it doesn't have to be that way. And I think that's a huge, huge conversation. So then, Heather, why don't you take us through PMS, PMDD? What's going on there?
I think there's a lot of people out there that are very confused on the difference and also not realizing that PMS itself is also a diagnosis of sorts. I think a lot of people are just like, oh, I'm just PMSing, but there is actually like a diagnostic criteria that can be like helpful to walk through with patients to see if they fit that. So PMS stands for premenstrual syndrome versus PMDD is premenstrual dysphoric disorder. So both of them do have some overlapping factors that come up in both of them. Mood changes can be a factor both in PMS and in PMDD. But often we do see in PMS, you have as part of that diagnostic criteria, it's either the mood changes and or some physical changes, as in like the breast tenderness, cramping, like some of those things that we mentioned before. Versus in PMDD, we tend to see it as more mood related as far as symptoms go for patients. Often we do see that it's quite severe to the point of I'm always screening my patients for suicidal ideology when we're talking about PMDD. And a lot of my patients too have those PMDD symptoms even in those 2 weeks before their period. So by the time ovulation happens, they're already starting to see those mood changes and those mood shifts. Obviously, the severity of either of those conditions looks different depending on the person, but often I do talk with patients. We do see a lot more of those mood changes specifically with the PMDD, but we still can have some of those mood shifts happen with PMS as well.
Anything else you guys want to dive into before we do rapid fire? Everyone's scared.
Rapid fire.
This is how I like them. A little bit scared. But I think it's really helpful for people to see. Like, I'm going to start doing more rapid fire. So, for any of our team who are listening to this now, they're like, oh no, she's coming for me. But this is how we do it on calls. Something comes up, we're troubleshooting, we're all contributing thoughts and going through things. And so, I think it is really helpful in these group calls for people to get a sense of how we navigate. And we call it like DDXing, right? Or how we're explaining something to a patient. So, I want you guys to go through it like you're explaining it to a patient, but I've got lots here.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the waitlist as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So, let's dive in. What's estrogen dominance? Is it a thing? Is it not? Michaela, take estrogen dominance.
Favorite term. I listen a lot to you when I learn new things, but is it a thing? I'm going to go with no. I think it's a really sexy term that works really well on social media and brings a lot of people in. But essentially, you're looking at a mismatch between estrogen and progesterone, usually between the second half of the cycle. And so it's less about necessarily being dominant in estrogen and what's actually causing the mismatch between those two hormones. I think that's a really big thing and it can lead to a lot of symptoms. And people use that term, and that's fine itself. But I think it's important that we just understand that it's not like a diagnosis or a thing. It's a sign of an underlying imbalance. Like those symptoms are a sign of something else underlying. And it's all about how every hormone's impacted by every hormone and our ability to produce those hormones at the level that they need to be there and all those types of things.
Anything to say on that, Heather?
As far as like the estrogen dominance piece, I think you covered that well, but we can see signs and symptoms that happen when we're in a little bit higher of an estrogen state, and that we see a lot of cycling, as we mentioned before, of histamine. That estrogen and histamine will feed back on each other in this feed forward system. So if we're in a higher estrogen state, that will also increase histamine, and higher histamine will also increase estrogen. And that can show up even in some of those symptoms, like those menstrual headaches that you're getting before your period, like clotting before your period, more pelvic pain and cramping. So those things can show up as well. It's not so much that like estrogen is the problem or that estrogen is dominant. It may just mean we need to support some of the other underlying hormones. Maybe we need to support ovulation, progesterone, and most likely we probably need to figure out what's happening with histamine and bring that down as well.
No. And I always say, you have a diagnosis when you test something over and over again and it proves true. And the use of the word estrogen dominance is not the case. So, for example, Heather's with child. If we tested her estrogen right now, it's going to be through the damn roof. That's why you can get like congestion during pregnancy and itchy and nauseous and like all of these things. But that is not a situation that is associated with a ton of breast tenderness and heavy flow and thickening lining and all of those types of things. Like, obviously, you're pregnant, those things can happen for other reasons. But the moral of the story is I have tested my labs and had quite high estrogen and felt fucking fantastic. And so it's not that one thing is correlating to the other, which is the point that we're getting at. Estrogen's not the villain here. But let's talk about on the other side of that, low progesterone. What does that mean? Because sometimes people feel estrogen dominant when their estrogen is normal, and it's just that they are not either adequately making progesterone or they're not ovulating. Let's roll that. I'll let you start, Michaela.
When I think of low progesterone, I think ovulation plays a really important role in that because when we ovulate, what the egg that's ovulated has something on it called a corpus luteum that produces progesterone. And so, if a woman has an anovulatory cycle or isn't ovulating, essentially, we don't get that nice, robust progesterone rise. You're still getting estrogen being produced, but you're not getting that progesterone. That's where we look at kind of the relative balance between those two hormones. And so that's something to definitely think about from a progesterone standpoint.
What symptoms, Heather, do you see in those situations? when someone
Yeah.
is like anovulatory or they're not making enough progesterone? What are some of the things you pick out?
Once you ovulate, essentially in that luteal phase, which is the second half of your cycle, more or less, it's kind of a fixed 14 days if you are ovulating. If you're not at the point of ovulating, usually we're going to start seeing longer cycles and we're going to start seeing more cycle changes. It's also, I think a lot of women don't realize this, but it's the drop in progesterone that you get that signals the start of a menstrual bleed. So when that little corpus luteum on your ovaries starts to shrivel up, and it's not there anymore, creating all that progesterone, then that is actually what starts you to bleed. And so sometimes if you're getting that happening a little bit early or you're having lower levels of that progesterone, that can look like some spotting before your period as far as like actual period changes. And then progesterone itself too helps a lot with sleep. It helps with mood. So we do see a bunch of those kind of symptoms showing up too if we're seeing that progesterone is lower.
That was another thing I was going to talk about. So I'm glad you brought it up. All these people who are 3 days before their period, they can't sleep. What's going on there? What are some of the things that you think about in that situation?
I mean, lower progesterone for sure could be part of that.
Yeah.
I think histamine in that situation too, because
Yeah.
there's a really large connection between histamine and circadian rhythm. And so sometimes you see that a
What's the
little bit.
circadian rhythm?
Oh, circadian rhythm is the 24-hour clock that your body kind of functions on. Not kind of, it does. Yeah, mediated by light, food, movement, all those good things that signal to our body what time it is and when it should be doing certain things, like sleeping or being awake or digesting.
We're making inflammatory compounds. This is part of why people feel so awful when you're sick. You know, when you wake up in the morning, you're like, oh my God, I feel so awful. And then, like, right around dark, you start to feel awful again. It's because your immune system's on a circadian rhythm. That's a period of time that your immune system's coming up. You're feeling so trashy. And so I use that example to patients when I'm talking about their period or symptoms that are coming up at night, et cetera, et cetera. Like, it's not different. The signs of inflammation is the signs of illness. A fever is inflammation. Congestion is inflammation. All these symptoms are inflammatory. Brain fog, energy changes. These are all like fundamentally there's an inflammatory component to almost all of them. And so it's whenever we look at those daytime versus nighttime symptoms, we have to be thinking about how that immune system plays in 100%. Yeah. What are some other things with sleep?
Generally, nervous system dysfunction. I'm always thinking, like, let's give some nervines to you, patients.
This sounds obvious, but it's really tough. But just the world we live in today, it makes it really hard to focus on having good sleep hygiene. I know about this stuff and I preach about this all day long. And I still personally am like, it is hard because, especially now that I have a kid, right? Your work hours is outside and your kid goes to bed. So you're like 8:30, 9:30 on your computer trying to catch up. Then it is very difficult, right? And the stress that we're kind of under nowadays. I say to my patients all the time, like, you're not going to fall asleep while running away from a bear. We have to give ourselves time to wind down and we have to actually support our bodies from that standpoint. And I think we can use nervines and supplements and stuff like that. But part of it is you do have to like come to some harsh realities about how you're living your life and make some changes, try and reduce those stress hormones and tap the nervous system out.
So yesterday, I was reading a study on turning your phone grayscale. Technology for our technology issues. The meta-ness of this does not evade me, let's be honest. We have like the eye brightness, right? So it takes the blue light out of the screen so that you're not getting blue light in your eyes to tell your body it's daytime when it's nighttime. We have all these things, but there was a study done that showed if you turn your phone grayscale, then you don't get the same dopamine and reward structure. So you don't actually get that same drive towards your phone. So I set up my phone so that at sunset, which at this time of year is like in 10 minutes, but it turns grayscale and takes all the blue out of the screen. And it is the trippiest thing. And last night, I like truthfully, I don't know if it's because it's still new, but I like hated looking at my phone. I was like, I clean the house. You know what I mean? I was doing other things. I would listen to it. I was listening to an audiobook, but I didn't want to visually see things. So I think sometimes there's those hacks that you can get to break those cycles as well when it comes to sleep. We should do an episode just on sleep though.
As we all change our phones to grayscale.
Yeah.
I know. I know. I was like, this is so interesting, but if there's research, I'll try it. Okay, so let's dive into, because we got through sleep issues, let's dive into libido changes throughout the cycle. How do you guys talk to your patients around that? Obviously, I'm going to qualify this whole conversation. Libido has a lot of things that play into it. It's your mental emotional state, your relationship with your partner or partners. It is how you feel in your body. It is a history of sexual trauma. It is a history of control related trauma. There's so many things that go into libido. I am desperate to have a sex therapist come on here and talk about some of those things. There's a few that I'm in talks with because I think it's a really important conversation to have. But let's talk about, like, just from a physiological perspective, what's going on with some of those libido changes that happen throughout the month. We all have kids, let's be honest. We can talk about this.
Well, what I tell patients is your libido, like outside of all the factors that you mentioned, is essentially your body trying to get pregnant, right? Like I tell my patients, we are capable of amazing things, but like when we really pare it down, we're here to procreate. And as females, we're only fertile for a couple days of the month. And so that typically it's those fertile days, which would be around your ovulation, is when certain hormones, testosterones do tend to be higher around that time, but when your libido in a healthy individual should go up. And you should notice clear changes in your libido around those times of the cycle. And so when we look at things that can impact that, if people aren't having ovulation, if they aren't ovulating, then they're not going to get those changes of hormones. I'm sure we could start a whole podcast on the next thing I'm going to bring up, but if you're on something that's preventing ovulation, like a birth control pill or with an IUD, the big joke is it prevents pregnancy because you don't even want to have it anymore because you're
Yep.
not ovulating that natural rise in the sex drive like you would expect with someone who's ovulating in a really healthy way regularly.
So you can clip out this portion for all you ladies. We're only meant to have sex 2 days a month. This is a fact. Scientifically, we're only meant to have sex our 2 fertile days. So every other day of the week, our partners can have off.
I think it's important for women to really know that though, because I think there's a lot of shame around like, well, I don't like it doesn't match my partner's, but I'm like, it's not supposed to.
They
Like,
want to have sex all day, every day. Like we've all been 20. It's fine. You do you. That's fine. But I think there is something to the conversation about biological rhythms. When you are 2 days before your period and your vagina is dry and uncomfortable, which we're going to talk about in a second as well, because that comes up, you're bloated, you're constipated. I'm with ya. You know what I mean? I'm in there. I drink the Kool-Aid. We're on the same page. It's okay to have those periods of time as well. I think exactly to your point. It's just if there's no rhythm to it. Like I have patients that are like, I could care less any day, any month, any year. I couldn't care. That's where we dive into other components in a big way for sure. Anything to say on that, Heather?
I think it's helpful for women to actually talk about it because I think there's a lot of either stigma behind talking about it or just this feeling of, oh, I should just be in the mood all the time and be able to match my partner. And so being able to understand those rhythms for yourself can be really helpful. Like, as Dr. Michaela was saying too, in that follicular phase, as you're starting to get more of your estrogen kind of popping back up again, you're going to likely start to feel more of that libido versus the second half of your phase, as you said, Dr. Sarah, right? When you're dropping all of that progesterone and your estrogen and feeling all of those things. So, like, normalizing that, not that it's pathological, but it's actually part of our physiology that we can feel that way, I think is super helpful as well.
So then let's speak to what we just alluded to and something else we do not talk about. And we do have an episode on discharge, but let's get into the BV yeast conversation before, during, after a period. That is something I hear about a ton. People are like, there's like a smell right before my period. Or like there's a weird discharge. I'm like, yeah, let's talk about it. You know what I mean? Like, let's give her. And they're so uncomfortable, but it's such a huge metric of health. And so, walk me through what are some of the things that you see and think about clinically with that?
I talk with my patients always a lot about discharge, and even from like the perspective, there's the BB kind of perspective, but
What's
also,
BB? Sorry, I said it. You're not
yeah,
allowed to.
bacterial vaginosis. I know we talk in so many acronyms that we just, yeah, we're gonna break it down.
I love how I do it. And then I'm like, but you can't.
Yeah, so there's all of the infectious kind of components, but before we even talk about those pieces, I think it's helpful to know that your discharge could and should look different throughout the cycle, especially like when you get to ovulation as well. A lot of times people are like, my discharge looks really weird around ovulation. I'm like, oh, is it like egg whitey? Is it like really stringy, stretchy? That's what we'll see as we're getting a big peak in estrogen right before we ovulate. So that's important to differentiate between other forms of discharge that you're gonna maybe see if you do have any types of bacterial vaginosis, yeast infections, things like that that could show up around the period. But then when we actually get to having some of those more itchy, irritated, smelly discharge like around our period, often that can happen as we're having a decrease in acidity of the vaginal canal and the vaginal environment with more of that menstrual blood. So the menstrual blood ends up being a lot more of a basic pH, and that can also affect that propensity to actually have some more of those infections showing up around that time.
Michaela, any other thoughts?
I was just going to say pH is a really big component in discharge and infections, but estrogen can really alter that because of the gut, or not the gut microbiome, although it's connected to the vaginal microbiome. The vaginal
Your
microbiome
anus and your vagina are friends. This is what we say all day.
is close.
They're friends. They're close.
There's no separation. But the estrogen levels will influence the vaginal microbiome, which will then sort of change the pH. And so some people, when estrogen peaks, like, yes, you can have like the ovulatory mucus and stuff like that, but you can also have surgence of different pathological types of discharge and itchiness and those types of symptoms as well, with various levels of estrogen within the cycle too.
I get good reminders from my patients every day. This is why we call it the practice of medicine. I was talking to a patient and she was saying, oh, yeah, like right around ovulation, I have more discharge. And I was like, okay. And then didn't think much of it in the first couple of visits. And then I just could not figure out one component of her pelvic pain. And so I was like, okay, tell me more about your discharge. Because pelvic pain can also be from inflammatory events in the vagina. And we know our treatments, we know they work. So I was like, okay, you're not this much better by this point. Like there's some other factor. And so she was like, oh, yeah, the discharge I get at ovulation is like foamy. I was like, tell me more. She's like, I've seen egg white things before. I just thought mine was different. But she's like, yeah, it can get like foamy and bubbly. And I was like, we need a referral. So she went and she got swabs, and it was just a weird presentation of Gardnerella, which is BV, but she was able to get antibiotics. She went with the antibiotic route, which I do not blame her. If you have foamy discharge, let's do both. Like, let's do antibiotics or antiparasitics and do our treatments. And next month, no pelvic pain. Next period, no pelvic pain. So it's just a good reminder that just because you should have more discharge at ovulation doesn't mean it should be foamy. That's like what Dasha talked about mites on the podcast. You know what I mean? Like there's moments in your life where the image is just there. And you're just like, yeah, okay. But there are a lot of people who are going to have foamy discharge. Now you know, like if it bubbles, we should deal with it. There's certain rules to life. If your vaginal discharge is bubbly, let's get some treatment. So let's dive in on that lovely note. I'll do this one as my last one. I was going to get into thyroid stuff, but I'll do a whole nother thyroid podcast. I was going to be like, and what are the ways your thyroid issues show up during your period? Because I get that question all the time, but TBD, everyone, you can hear that one later. We've talked about period poops, but we didn't break down what that is. So, Michaela, I'll get you to run the causes of constipation with your period, and then right before your period. And then, Heather, I'll get you to run the causes of diarrhea before your period, because period poops can be either one. You can be constipated or you can have diarrhea. So, run me through that like week before, why people might get constipated versus why they might get diarrhea when they're bleeding. So, I'll get you to start, Michaela.
Yeah, so during the second half of the cycle, like the week leading up to when you have your period, that's when your estrogen and progesterone are both quite high. And those hormones itself do slow down the speed of the digestive tract just naturally. It's kind of like if anyone's been pregnant before, it can be very common to get constipated and get heartburn, and things just don't move from top to bottom very quickly, right? And that's, yeah, like it just doesn't. Everything is going opposite. And so there is a certain element of the estrogen and progesterone in the second half of the cycle. Again, we don't necessarily want to be constipated. And so there's things we can do about that. And I don't want to get into too many condition based things because we just said we were going to save thyroid, but that's definitely something
Yeah.
that is going
Thyroid
to,
and endo too, right?
yeah,
Like you can have adhesions.
yeah, are the two things that I do see most, especially when it's cyclical based stuff too. And I think there's like a little bit that's like, yeah, your things are going to moving slower during that time period. But again, it shouldn't be to the point where we're like missing complete days, we're straining, we're getting hemorrhoids, we're getting fissures. That is like crossing a line of this isn't considered normal.
Yeah. I'm like, as a society, we're absolutely full of shit. So chances are, if you're constipated during that window, it's because you have retained stool at other parts of your cycle. Again, period is your monthly report card. It's what's the check-in on your health. I have patients that don't poop for 5 days in a row before their period. I promise you that is remaining at other parts of your cycle as well. If you still eat during that window, that means that poop has to go somewhere, which means it's being stored. Like, fun fact, but it is a big one that I don't think we talk about very much.
Yeah, I feel like in this conversation, usually when I'm talking about period poops with my patients, I always bring up a side view of what it looks like inside the pelvic cavity. So if you can Google that right now and look that up, basically your uterus and your whole reproductive system is so close in proximity to your bowels as well that if you have endometriosis, for instance, those endometrial lesions can also show up on your bowels, and that can be very much impacting what's happening with your stools to the point of diarrhea, to the point of constipation as well, like with those adhesions. But then also, we have a lot more prostaglandins, which are these inflammatory molecules that show up even within our menstrual flow, within our menstrual blood, that also could contribute to more of that, like just a little bit more diarrhea, a little bit more inflammation showing up in the pelvic cavity. And so you can have some of those period poops happening that way. As Dr. Sarah was saying too, diarrhea can also show up because you're constipated. So I often will say you can have a bunch of fecal loading where you have a bunch of stool lining. I'm like showing my hands. A bunch of fecal loading lining the inside of the intestines to the point that if you have such a decreased caliber, things can just shoot through so much faster. It doesn't necessarily mean that you're not constipated, it actually probably means that you're really constipated. Those are always things that I'm looking at with my patients too when they're talking about those period poop changes.
But diarrhea at its fundamental base is really one of three things. It's that everything is moving through too quickly because you don't have time to extract the water. So if you're getting cramping in your uterus or cramping in your bowels, it moves through too quickly. You don't have time to extract the water. You have some kind of external inflammation or some kind of internal inflammation that is causing water to be pulled in. That's why when we look at traveler's diarrhea, when we look at all these conditions, it's fundamentally an irritant that's either working on the water channels or that is causing water to come in. It's at its core, it's so simple. It's just there's 20,000 different potential causes of each one of those things, and it's navigating those. But in either situation, a well-formed, healthy bowel movement. I don't do Bristol. I know I'm the weird one. You guys are all talking Bristol stool charts. I don't do Bristol stool chart very often, so I don't know what the normal is, but what's the normal one? Is it 4?
For
Still got it in me. You can Google it. You can look. You want like a fully evacuated. I go based on feeling because you can have a large, well formed, no undigested food, perfectly wonderful bowel movement. And you can leave that bowel movement and feel not fully evacuated and bloated and uncomfortable. And that's still an issue. We should be able to have that balance of fully evacuated every day. Like Michaela said, no straining, no fissures, no hemorrhoids, none of those things, not running to the bathroom, no urgency. Like we can have that muscle. Okay. Any other myths, anything else you guys want to clarify before we wrap up today's episode? It's been a great one. I love a little rapid fire. So I would love to hear from you guys if you liked it, and the audience, let me know, send us a comment, send us a message on Instagram. But any last minute words from you?
I feel like one of the things that Dr. Michaela and I talk about a lot, and we talk about with our patients a lot, is that you don't have to struggle with these things. I think there's so many times that we've normalized a lot of these things because we see them being common. But if you're struggling with period pain, if you're struggling with irregular periods, we can do thorough investigations, and Advanced Women's Health, we're really good at it. And you don't have to be struggling with this every single month. You don't have to feel like you're not yourself for 2 weeks out of every single month. So I feel like a lot more women need to hear that, and that there are answers for you and treatments that can be really helpful.
Yeah, I was just going to say, just because you're a woman doesn't mean that you have to suffer. And there's such a notion in our world that it's so hard to be a woman and you have periods and then you lose your period. And that also sucks. And it doesn't have to be that way. You just need to learn more about your body and what your body needs to function its best. And that's what we all love doing so much. So
Very
yeah.
good. Well, thank you both so much for coming on and being grilled. Welcome to the firing squad, to the audience. This is what we jam on all day. If you want to book an appointment with Dr. Michaela or Dr. Heather about all things period, and if you want to book about your kid, don't talk to me. Heather's your girl. And then it's through Advanced Women's Health Brooklyn. So thank you guys so, so much. It's been so much fun. We'll have you both on soon.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.